Welcome, everybody. We'll just give a few more minutes. It's not 6 o'clock yet. Thank you very much for your patience.
Right, it's just gone 6 o'clock, or it's about 6 o'clock. I'm not sure what time it is. I can't see. Adam, thank you very much for your willingness to present this evening. I do really appreciate it. It's a really important topic. In some ways, it's kind of an indictment on us as healthcare practitioners that we need to talk about respectful care. You would have think that was a given. But it obviously is not within our context. And so it is important for us to learn how to provide appropriate care to pregnant women when they present to our healthcare facilities. So Adam, thank you very, very much. And we look forward to your presentation.
Thank you, Prof. Ross. Thanks for the introduction. I think your watch is running 1 minute early, but I'm happy to start. Good evening, everyone. Thanks for the opportunity to present today. I'm a family physician based at St. Mary's Hospital in Outer West Durban, and I'll be presenting the safe and respectful care of women with one previous caesarean section in South Africa. The work towards this topic actually predated the CPD article, which was published in the SAFPJ earlier this year. And that was entitled Context-Sensitive Holistic Care of Women with One Previous Caesarean Section. So this all actually started in April 2023 when my co-author and I'll introduce her shortly, delivered a presentation entitled Management of Women with One Previous Caesarean Section on a provincial virtual outreach platform. Now, the evolution of titles from management to care to, holistic care to safe and respectful care may seem like semantic nuance, but it has been intentional, reflecting a shift in content from a primarily biomedical focus to one upholding respect and safety. So I'm joined on this webinar by my co-author of the article, Sister Avashni Naidu, who's a registered midwife in private practice. We used to work together in the state sector. And the shifting focus that I mentioned is largely due to her inspiration. So I just wanted to thank her for her input over the past year or so, which has contributed really to my development as a more holistic family physician. I also see Dr. Edward Nambasi on this call. He's a current colleague who has also been very instrumental in my development as a holistic family physician with an interest in obstetrics. I'll start with the presentation by going over my take-home messages. And then at the end, maybe if Vash wants to comment from a midwife's perspective, I'll give her the opportunity before we open this up to everyone for any questions. So my take-home messages are: number one, a pregnant woman who has had a previous caesarean section is always or should always be considered a high-risk patient. Respectful maternity care refers to the preservation of patient dignity and autonomy, clear communication by healthcare workers, and a birth experience that is positive and empowering and aligns with the patient's values. 3, safety should not compromise respect. 4, respect should not compromise safety. I'm not really sure which one I should say first, but yeah, it's just incidental that I wrote safety should not compromise respect as the first one. And then lastly, the model that I would like to propose for patient-centered mode of decision-making is firstly to look at amenability, then suitability, and then revisit amenability. It will make sense when I've gone through the meat of the presentation. So by the end of this presentation, I'd like you, the audience, to have a better understanding of the benefits and risks of both an attempt at a vaginal birth and a repeat caesarean section after one caesarean section, I'd like you to have a better understanding of an approach to the obstetric consultation of women with one previous cesarean section across the pregnancy continuum. And I'd like you to have a better understanding of opportunities and threats to holistic care. I'm going to start off with a case presentation. This is a 27-year-old female, Grav2 Para 1. She booked at 12 weeks and her booking bloods showed a positive rhesus status, a non-reactive RPR, and a reactive HIV status. She was commenced on antiretroviral therapy at booking. It's noted that she had a previous cesarean in 2015. At 37 weeks of gestational age, she presented to labor ward at 6 o'clock in active labor, noted to be 6 centimeters dilated with spontaneous rupture of membranes 30 minutes earlier. Her CTG was normal. The patient expressed agreeability to vaginal birth after cesarean section. I'll hereon refer to that as VBAC. I'm not sure how relevant it is, but the chart noted that she drank holy water for the past 2 months. Her next assessment at 8 p.m., she's 9 centimeters dilated, half a centimeter long, with the presenting part 3/5 above the pelvic brim, draining clear liquor, no caput or molding noted. 2 hours later at 10 p.m., she's still 9 centimeters dilated, fully effaced, presenting part still 3/5 above the pelvic brim, draining clear liquor, no caput or molding. The action is to put her onto the CTG, which is initially interpreted as suspicious with hyperstimulation. Intrapartum resuscitation is commenced, tocolysis given, aimed at the hyperstimulation, and the doctor is informed. The patient is seen at 22:50 by the doctor and booked for a cesarean section for fetal distress. The patient is in theatre within 15 minutes, and then 30 minutes thereafter, a male infant is delivered by cesarean section weighing 3.3 kilograms. Meconium stained liquor grade 3 is noted, and the APGARs are 1 at 1 minute and 2 at 5 minutes. And eventually the resuscitation is abandoned after 20 minutes and an early neonatal death is declared. Now, the details of this case were taken directly from another hospital's patient safety incident report, PSI report. And I'm doing this in an effort to demonstrate how documentation can skew assessments of PSIs. What we don't know from that case summary is what the agreed upon antenatal plan for mode of delivery was, what the indication for the previous cesarean was. We don't have CTG images. It's not clear if the patient was on continuous CTG, although reading between the lines, it doesn't appear to have been the case. It's unclear how long the trace was suspicious before action was taken, and it's also unclear what the reason for the delay in the doctor seeing the patient was. So what happened after this case? It was presented using only the PSI form in a facility clinical governance meeting, and the hospital management took a decision to halt VBACs. Looking at the cesarean section monograph authored in 2013 by the National Committee on Confidential Inquiries into Maternal Deaths in South Africa, it is stated that a facility should be should a facility be unable to comply with requirements for a safe VBAC, then an option, pending changes being made, is to do elective repeat cesareans for all women, or transfer all women with a previous cesarean section to another hospital for delivery. It's quite a drastic move that actually, I feel, temporarily threatens the reproductive rights and autonomy of women who attend the facility for antenatal and intrapartum care. In addition, careful consideration is needed looking at the longer term. So if we offer elective repeat cesarean sections to all women for a certain time period, whether it's short or long, it will create issues in the future with an increasing burden of women needing a repeat cesarean section. Anyway, the good news is that this facility, in a matter of weeks, managed to put together a quality improvement program that demonstrated to management that safety concerns highlighted by the previous case would now be resolved. This included a standard operating procedure, an information leaflet, a checklist for antenatal care from 36 weeks onwards, and one-to-one nursing as a standard for VBAC. And if this wasn't possible, the reason had to be documented in the patient's file. And lastly, there was also a poster displaying warning signs of uterine rupture in all labor suites. So, zooming out to the principles, pregnancy and labor are essentially natural processes which do not necessarily benefit from medical or surgical interventions. And as a community of practice, we have a duty to counter the creeping over-medicalization evident in both midwifery and obstetrics, both for individual and public health reasons. So on an individual level, we should be always trying to facilitate a positive experience for patients, and specifically in this case, a positive pregnancy and labor experience for each woman whom we support in her journey. And on a public health level, we need to be mindful about overburdening the already stretched health system with unnecessary interventions and their sequelae. Focusing specifically on caesarean section, it's important to have this intervention available as it's potentially life-saving for both mother and baby. However, it's also potentially life-threatening, not only in relation to the pathology driving the need for caesarean section, like eclampsia, for example, but also due to the specific complications of caesarean sections, such as hemorrhage, sepsis, venous thromboembolism, and anesthetic issues. I also want to point out there's an accrual of risk with multiple caesarean sections. So serious morbidity increases with the number of caesareans performed. Things like adhesions, surgical injury, placenta accreta spectrum, hysterectomy, blood transfusions. In the context of one previous caesarean section, all of these risks should be balanced against those associated with a VBAC, which decades ago was unthinkable. A publication from the early 20th century states, once a caesarean, always a caesarean. So in someone who has had one caesarean previously, there are three possible outcomes. One at the top of this chart is a successful VBAC. Going anti-clockwise, we can have an elective repeat caesarean section, and then further anti-clockwise, there's the possibility of an unsuccessful VBAC leading to an emergency caesarean section. This confirms the highest medical risk and potential for psychological disappointment. I think we can all empathize with this, given that birth is such an important life event for a parturient. And when I talk about medical risk, this can be considered in terms of maternal and neonatal, and these are displayed on the slides. In providing care to a woman who has had one previous caesarean section, our overall aim should be to support her right to experience a vaginal birth, should she so wish, whilst maximizing the chance of a successful and safe endeavor. And just a word about women's wishes. Although caesarean section without medical indication is not available in the state sector, South African guidelines do recommend VBAC in the absence of any contraindications, but because of the possibility of a repeat caesarean section being close to 40%, a woman's preference for mode of delivery should be considered. This preference should ideally be based on the woman having access to correct information, including counseling about all three options. So it's not just simply repeat caesarean section on request. We need to have a good understanding of the content of this slide if we're to be competent in counseling women with one previous caesarean section. We should be able to guide them through the information here based on their risk profile and inherent preferences, validating correct knowledge and correcting misconceptions. I just want to point out two aspects. In the VBAC disadvantages, I mentioned the risk of uterine rupture. That is less than 1%. We don't have great literature from our context that less than 1% comes from higher income countries, but it's important to note it has maternal and neonatal sequelae. And then on the perineal trauma side, this includes pelvic organ prolapse, urinary incontinence, and anal sphincter injury. So I talked about offering care across the time continuum. The time continuum of care provided to women with one previous caesarean section actually begins before the first caesarean section. The higher the primary caesarean section rate, the higher the repeat caesarean section rate will be, and a big contributor to the likelihood of having a caesarean section in the index pregnancy is having had a previous caesarean section in previous pregnancies. To avoid unnecessary caesarean section, our health system has developed two interventions. One is improving the knowledge and skills of healthcare workers related to the careful assessment and management of women in labor for possible cephalopelvic disproportion, fetal compromise, and a delayed second stage. This is all done via ESMO drills. Secondly, Caesarean section auditing with quality improvement projects emanating from the auditing process should, in theory, on a longer term, prevent unnecessary Caesarean section. Moving on in the time continuum, to after the primary Caesarean section, we need to focus on debriefing and family planning. Debriefing serves two purposes. Number one, it empowers the patient with information for the future. We can check her understanding. I find generally a good way of checking a patient's understanding when I, as the provider, am initiating information sharing, is to ask them how they're going to explain this event to their family or other people. So what are you going to tell to your family about how the birth happened and why it happened that way? It's important to note that some women begin their decision-making for future mode of delivery in the immediate postpartum period of their primary Caesarean section. For example, if they had a prolonged labor with poor access or no access to analgesia, and they experienced obstetric violence, then they may be walking out of the hospital having decided on a Caesarean section for future births. That said, for most people, the postpartum period is a blur, and ideally we should schedule a refresher and debrief at a later stage when the woman and their partners may be more receptive to information. The second purpose of a debrief serves as an opportunity to identify patients who need greater support. It's impossible to dig deep with everyone about whether their birth experience was empowering or not, but a lot of hidden trauma will remain hidden with a simple, "How are you doing today?" So I suggest prioritizing vulnerable groups for more in-depth support, which can be delivered by the medical team, the nursing team, and a social worker once medical counseling has been completed. In my experience, we send the patient to the social worker, and the social worker sends the patient back saying, "You as the medical team haven't really explained what the cause and consequence is here. She needs to understand that first, and then I can go on to supportive counseling." Moving on to family planning, the ideal contraceptive would be long-acting and reversible so that we can afford the woman or couple the ability to easily control the interdelivery interval. The interdelivery interval is the period between the last delivery and future anticipated delivery. The Royal College of Obstetricians and Gynecologists mentions a minimum of 12 months, and the parallel American authority suggests 18 months. There's nothing mentioned in our South African guidelines. Other research and guidance talks about interpregnancy interval, which is from the last delivery to the next conception, and they talk about a minimum of 6 months. So we don't really have any context-sensitive definitive guidance about this other than 12 months being too short. So now we're seeing the same woman in her next pregnancy. And in 2016, we had the Bank Plus guideline published. This advocates a shared care model, and I'll talk you through it. So the woman books with a basic antenatal care provider. She's assessed as ineligible for bank, and she's booked to see a doctor at her next visit within a week. The doctor reviews the history and initiates mode of delivery planning. The woman should have access to early ultrasound to assist with accurate gestational aging and placental location. If there are no additional risk factors found, she can continue with basic antenatal care at her nearest site until 36 weeks gestational age. During this time, her maternal health or her health would be optimized with the hemoglobin being optimized, HIV viral suppression, adequate weight gain. And then from 36 weeks onwards, she would see a doctor again to more formally plan the mode of delivery. And this can be done either as an outpatient or in a maternity waiting home if in a very rural location, either to await spontaneous onset of labor or until a planned elective Caesarean section date. So in the antenatal phase, we need to assess a patient's suitability for VBAC, and these are the factors that are accepted within the South African context as prerequisites for a VBAC. Number one, a single lower uterine segment scar, so a previous myomectomy on the main body of the uterus would not qualify. No history of uterine perforation or rupture, an absence of a bad obstetric history, a non-contracted pelvis. I've put maternal BMI of less than 40 in brackets. It's mentioned in the 2016 National Guidelines for Maternity Care, which, by the way, are soon to be updated, as an indication for elective repeat caesarean section. However, it's important to note that the maternal and neonatal risks increase with increasing BMI, regardless of the mode of delivery. So as an isolated feature, this should not tilt the balance in one direction or another. Next, we have a reasonable estimated fetal weight. What is a reasonable estimated fetal weight? The caesarean section monograph from 2013 suggests 3.2 kilograms or less, which correlates to a symphysofungal height of 38 centimeters. And if that's exceeded, it can be a VBAC is permissible if the patient is reviewed by an experienced obstetrician and felt to be a good candidate for VBAC. The 2016 national guidelines go a little bit higher, and they say that an estimated fetal weight exceeding 3.5 kilograms, which equates to a symphysofungal height of 40 centimeters, should prompt one to be very cautious in allowing a VBAC. It's important to note that estimates of fetal weight should also be compared against the size of the mother. So in essence, there's no real absolute fetal weight limit, but VBAC attempts with estimated fetal weights greater than 3.2 kilograms should be managed with a lower threshold to resort to an emergency caesarean section. Moving on, if there's any compelling obstetric indication for an elective repeat caesarean, that should be honored. And lastly, HIV is not a consideration. We have a robust VTP, or vertical transmission program, and that has essentially renegotiated the reproductive rights of women living with HIV. So we talked about the biomedical obstetric assessment guiding mode of delivery after one previous caesarean section, namely suitability for VBAC. I want to now start considering a more holistic approach. Firstly, we have to consider the manner of counseling about mode of delivery. If we leave this, we leave the counseling and the planning until 36 weeks, we've missed lots of opportunities. The health system should be offering information on an ongoing basis, which will allow good shared decision-making later on. The worst case scenario, which I'm sure all of us will be familiar with, is taking consent intrapartum. The possibility of an emergency caesarean section representing a shortcut to avoid pain is real. Secondly, we need to ask ourselves if we lack the capacity to adequately counsel. Should we just be accepting that we are short-staffed all the time, we don't have enough time or capacity to offer anything besides a one-size-fits-all approach? I would encourage us to say no. Women who have had a previous caesarean are a high-risk group, and our approach needs to be cognizant of that. One thing they require is ongoing engagement. So are we using the bank platform effectively to engage with women? We need to identify those women who need additional counseling and provide it accordingly at each antenatal visit, a little bit like antenatal classes in a more privileged setting. Basically, we end up eating the elephant one bite at a time. In our counseling agenda, we should remember to remain patient-centered. So how do we do this patient-centered, additional focused counseling? Well, it can be a simple intervention like taking a few extra minutes at each antenatal visit with high-risk patients, or we can organize our antenatal clinics so that women with previous caesarean section are seen on a particular day, and on that day relevant group health education is offered. We can also be more creative and look beyond ourselves as the health system. We could establish peer support groups, identify patient ambassadors who could be encouraged to engage with other pregnant women as part of extended antenatal support. And we could use virtual platforms with some patients, perhaps as simple as targeted messages via Mum Connect based on a patient's risk profile. Lastly, if you're experiencing a difficult engagement around a previous birth experience or future mode of delivery, they may be hidden wounds which need to be exposed earlier rather than later. Otherwise, they will resurface close to the time of delivery. Women with previous birth trauma are expected to go through their pregnancy essentially on survival mode, which doesn't bode well for labor if they end up attempting VBAC. Stress hormones can antagonize natural hormonal support of labor, and this has been referred to as the load shedding of labor in some circles. This brings me to the point of conscious awareness. Teaching a woman to be aware of her body will facilitate relaxation and breathing techniques in labor. If the body is left to its own devices, history, whether it's due to muscle memory or some other factor, will tend to repeat itself, and we commit to intervening surgically on repeat. Regarding birth companions, there's a wealth of evidence about the benefits of them, whether it's personal birth companions or professional birth companions, which are referred to as doulas. This is now reflected in recent national minimum standards, which encourage every labour ward to have a policy of allowing a companion of choice to accompany a woman during labour. Given the pitfalls associated with VBAC, this is especially true in women who have had a previous caesarean section. So I've previously mentioned the Caesarean monograph, written as an intervention to address a rising case fatality related to caesarean section. As an aside, gratifyingly, due to our efforts and the efforts of our principals in the health system, the case fatality rate related to caesarean section has been falling for at least the last 2 triennia. Anyway, the monograph warns against assessing amenability only, which is something that we often see in clinical practice, and guiding healthcare workers toward assessing suitability first. By suitability, we mean assessing whether it's going to be safe to go ahead with undertaking a VBAC and whether the attempt is likely to be successful. After that, we should ask what the patient's wishes are. Now, as we know, the core skill or superpower of a family physician is patient-centeredness. With this in mind, I want to suggest a hybrid approach or modified approach, whereby the patient's perceptions are considered first. So practically, I do this by asking what thoughts and feelings a patient has about future mode of delivery, which often brings up a question like, will I be able to deliver naturally? To which I would respond, that's a really good question. It's a relevant question, which I hope to be able to answer by the end of the consultation. So really, your opening question when it comes to mode of delivery counseling should be based around ICE cubed. I'm not sure if this acronym appears in general family medicine literature, but it was taught to me by Prof. Mergan Naidu when I was a registrar. Ideas, concerns, expectations, emotions, and effects. We need to break down barriers and validate concerns using a humanized approach. And if we don't tap into patients' fears, they will feel unheard and we will be unable to assist them. In 2020, Ahmed published a semi-quantitative knowledge, attitudes and preferences CAP study with data collection performed in the state sector antenatal clinics in the Western Cape. Despite all participants being medically eligible or suitable for VBAC, only 49% opted for this mode of delivery, the remaining 51% preferring elective repeat caesarean section. Now, it was a small sample size, so it precluded comment on the impact of many demographic factors, most notably age, cultural background, highest level of education, and previous long labor. Whether or not statistically significant, what was demonstrated was that there was a potential trend. And I do want to mention that internationally, culture or cultural influence is validated as an important consideration, with some cultures upholding vaginal delivery, whether on its own or following a caesarean section, as a rite of passage of sorts. For example, literature from high-income countries shows a strong preference for VBAC, appearing to be driven by a belief that vaginal birth is normal and has some intrinsic value. In this study, 68% of Black non-South Africans preferred VBAC, whereas 43% of Black South African citizens preferred VBAC. As I mentioned, this wasn't statistically significant. Two statistical findings two statistically significant variables included relationship status and healthcare worker influence. So with relationship status, women who were cohabiting with their partners were more likely to choose VBAC with a p-value of 0.011, and with healthcare influence, participants to whom an elective repeat caesarean section was suggested were more likely to choose this mode of delivery, p-value of 0.001. Remember, this is amongst participants who are eligible for VBAC, so it really shows how much patients can be influenced by us as healthcare workers. Interestingly, a prior successful vaginal delivery, whether preceding the primary caesarean or a successful VBAC, was not found to be associated with a patient's preference. In those who preferred VBAC, most cited a faster recovery and discharge as their main reasons. Looking further into this study, it's interesting to note the spread of factors affecting women's decision-making. A clear preference for elective repeat caesarean section from an early phase in pregnancy can be driven by a fear of vaginal birth from a previous negative experience of attempting but failing to achieve vaginal delivery, prolonged labor with associated maternal exhaustion, inadequate pain relief in labor. Women may feel the need to restore a positive emphasis on their birthing experience, which they feel the predictability of an elective repeat caesarean section provides. There is also the less common entity of tocophobia, which is an unreasonable fear of childbirth. Now, although long labor, which the author had specifically hypothesized was going to be a driver of amenability, it actually had no statistically significant relationship with the mode of delivery preference, but general pre-existing beliefs did. And these beliefs were driven by personal experience, word of mouth, and social media. With that, I want to conclude my discussion about the antenatal phase, but briefly mention the options available to a woman who is post-dates. Although mechanical induction is an option, it is important to note that the likelihood of successful VBAC diminishes the further past the expected date of delivery gestational age is. The more mature fetal head molds less easily in the maternal pelvis. Moving on to intrapartum care. Intrapartum care of VBAC should occur at an appropriate site, so one where there is access to safe emergency caesarean section facilities 24 hours a day, and one with emergency blood available on site. Now we're in the intrapartum phase of a VBAC attempt. So these are the principles in intrapartum care. Number one, the patient should be assessed as a priority. Number two, the mode of delivery should be reviewed on arrival and actually on an ongoing basis. So we're reassessing suitability and amenability, especially if arriving in advanced labor. So if the patient arrives fully dilated and the initial plan was for elective repeat caesarean, the patient should be counseled about the situation and the realistic option of VBAC if she remains suitable but was previously not amenable. We need to establish IV access but support oral intake. Insertion of urinary catheter and continuous CTG or cardiotocographic monitoring are recommended by the 2016 maternity care guidelines, but are not mandated in the 2013 caesarean monograph. When it comes to CTG monitoring, one should be aware of the elephant in the room, which is an unconscious bias in us as healthcare workers. So are we looking to achieve a VBAC or are we looking to cut? And then depending on the unconscious bias, a suspicious CTG may be acted upon differently. Then looking at the partogram is really a wonderful tool as it not only charts the progress of labor, but also prompts the monitoring of the maternal-fetal condition according to a schedule. And if strict intermittent fetal monitoring is not possible, then continuous CTG is recommended. Lastly, we would avoid the use of uterotonics, but would be open to the use of tocolytics if an emergency caesarean section is not immediately available. So the whole concept during labor is to try and optimize success without jeopardizing safety and vice versa. Incidence of uterine rupture associated with VBAC in developed countries is between 0.3 and 0.9%. Considering the factors which contribute to the risk of uterine rupture, we've already discussed patient selection as guided by suitability assessment. In terms of human resources, uterine rupture is more likely to occur if there are insufficient staff to monitor the materno-fetal dyad adequately. On this note, intrapartum care, even if the patient is only suspected of being in labor, as opposed to being in established labor, it should occur in labor ward. Moving on to optimizing success on the right, When I write respectful care, I mean the preservation of dignity, autonomy, and clear communication. So a competent healthcare worker will encourage oral intake to prevent exhaustion. They will uphold autonomy through considering a woman's preferred position during labor and delivery, preferably one which does not compromise pelvic outlet diameter and additionally harnesses the assistance of gravity. So the classic fully dorsal supine is a poor birthing position. These competent healthcare workers will also support instinctive rather than directed forceful pushing in the second stage of labor. They will offer analgesia in both pharmacological and non-pharmacological forms, which includes position changes, superficial heat and cold, patterned breathing, and massage. And lastly, as I mentioned before, there is great evidence for birth companions specifically decreasing pharmacological pain interventions and supporting a shorter labor experience. Now, moving on to a failed VBAC. Is failed VBAC a good phrase when it comes to empowering laboring women? Failure is usually associated with negative connotations. Maybe we need to change the narrative. Anyway, in the absence of a better word, these factors should guide us towards declaring a failed or unsuccessful VBAC. So there's the progress of labor with a prolonged latent phase, and in the active phase, anything that falls to the right of the alert line is considered poor progress. That's in the presence of ruptured membranes. Also, a delayed second stage is poor progress unless the patient is suitable for an assisted delivery. And then we need to consider whether the woman has a ruptured uterus or is about to have uterine rupture. There are maternal and fetal indicators thereof. I don't want to go through them in detail, but just to focus on shock index. Shock index is defined as the heart rate divided by the systolic blood pressure. So if a mother's pulse rate is 91 and the systolic blood pressure is 100, this is 0.91 and is a cause for concern. Now, declaring failure, it's a spectrum. It's never black and white, but the following non-modifiable variables can be considered when trying to ascertain the likelihood of success. And perhaps it's more useful to consider these variables being inverted, predicting the likelihood of a failure or predicting the likelihood of an emergency cesarean section being needed. So I'm not going to go through them all. If we have a patient, a parturient who's 42 years old, so she's not less than 40 years old, has a BMI of 36, so her BMI is not less than 30, and is 41 weeks pregnant, so her gestational age is not less than 40 weeks. She's wishing to pursue a VBAC. She's been previously assessed as suitable. Great, but we need to communicate sensitively to her that there are a few things stacked against her rather than bluntly saying that she will fail or that she needs an emergency cesarean. Antenatally, we can share information that there is a higher chance of needing repeat cesarean, and intrapartum during a VBAC attempt, we may have a lower threshold to recommend an emergency cesarean. I just want to point out something on the third variable, which I didn't mention earlier. We were talking about the ideal interdelivery interval. So we've said that definitely we would stay clear of an interdelivery interval of less than 12 months, maybe even less than 18 months. An interdelivery interval of greater than 10 years is interestingly associated with failure, but not associated with uterine rupture. Anyway, just focusing again on the word failure, which is marked in quotation marks, my emphasis here is on sensitive communication. We need to be aware of the psychological consequences of how we communicate. I've never been in labor, nor am I likely to be at any point in the future, but I used to be a long distance runner. And if someone told me ahead of a marathon that I was likely to fail, I'm not sure if I would have run the marathon. Moving on, I've already mentioned that emergency cesarean section is more dangerous an option than both elective repeat cesarean section and a successful VBAC. Hence, one should exercise caution when taking a patient for a cesarean section due to an unsuccessful VBAC attempt. It's beyond the scope of this talk to outline an approach to dividing adhesions, but I must mention them as an important surgical entity to deal with when doing a caesarean section after a previous caesarean section. Just wanted to mention briefly dehiscence versus rupture. Uterine dehiscence occurs when the fetal membranes are not ruptured and the fetus is not outside the uterus, with the peritoneum usually covering the defective opening. Morbidity and mortality are not increased as they would be with uterine rupture. And uterine rupture is the complete separation of the myometrium, usually with extrusion of the fetal parts into the maternal peritoneal cavity. And it can be concealed, asymptomatic, or it can be overt, symptomatic. Moving on to the postpartum phase, if a patient has had a successful VBAC, she should not follow the normal 6 hours observation and discharge route. She should be monitored for around 24 hours. We're looking essentially for signs of late uterine rupture, which can occur. So similar things to what we mentioned earlier, a shock index of greater than 0.9, lower abdominal pain, evolving or escalating severe abdominal tenderness, postpartum hemorrhage, hematuria. With that said, there is no need to examine the uterine scar manually. And also of note, forceful removal of an adherent placenta is not advised. With a caesarean section following a previous caesarean section, the care of the woman should follow the standard post-caesarean care schedule for the facility unless there were significant intraoperative events or findings. In terms of discharge plan, we should avoid scanty summaries. It's ironic how risk management changes as soon as the baby has been delivered. You know, maternity case records, which were tomes, end up being summarized into one line. Something that I talked about in the first slides, the notion of a debrief. We are trying to avoid unresolved issues from a negative or traumatic birth experience. There's a lot of literature from midwifery and psychology circles about the emotional scars of negative birth experiences, specifically around caesarean section. This is mirrored by a lot of content on social media, some from support group circles. If we send someone home with guilt associated with a failed VBAC, it could have negative psychological consequences, not only for the mother in the immediate future, but also for the baby, who one day will be an adult, and their personality and health may well be influenced by how the mother processed that birth. So I feel that as a health system, we're good at identifying some vulnerable groups like teenage pregnancies or women who have had a previous caesarean section, but our interventions are not as comprehensive as they could be, even in the light of resource constraints. On to clinical governance. Facilities should ascertain their VBAC success rate by dividing the number of vaginal deliveries following caesarean with no adverse maternal or neonatal deaths over the total number of VBACs attempted. I think the Academy Next 5 program carries the motto, "You didn't come this far to only come this far." I think this motto is applicable to a low VBAC success rate. We shouldn't be complacently offering VBAC to women if our success rate is less than 50%, as essentially the most likely outcome after all of the effort and pain of labor will be an emergency caesarean section. We shouldn't accept such and should explore the reasons behind it. A low success rate suggests the need to explore our facility's patient selection and intrapartum care practices. And I just wanted to share some findings from local studies. At a rural district hospital, we had a 58% VBAC success rate, and at urban tertiary and regional centers, we had success rates closer to 30, the mid-30s basically in terms of percentage. So I keep talking about context, and in this slide, I want to consider other contexts. Other health systems can afford to be more liberal. In the UK and Australia, for example, one-on-one care is standard. Steroids are offered for lung maturation up to 39 weeks in the context of an elective repeat caesarean section. And there's cautious acceptance of some practices which are basically a no-no in our setting. So a VBAC after 2 caesarean sections, induction and augmentation of women. Notably, there is a 3-fold risk of uterine rupture, but with the more advanced interventions and safety nets, VBACs on a background of induction and augmentation can remain safe. Delivery of a macrosomic fetus, so over 4 kilograms, is cautiously accepted. It's less likely to be successful, but it is accepted and offered, and a shorter interpregnancy interval. Remember the difference between interdelivery and interpregnancy interval. And they, in their context, are achieving VBAC success rates of 72 to 75%. So it really goes to show that even with a higher risk profile, the higher quality safety nets translate to a higher success rate. So I want to go back to my take-home messages. Number one, a pregnant woman who has had a previous cesarean section is always a high-risk patient. Respectful maternity care refers to the preservation of dignity and autonomy, clear communication by healthcare workers, and a birth experience that is both positive and empowering and aligns with the patient's values. Safety should not compromise respect, and vice versa, respect should not compromise safety. And the model that I want to propose for a patient-centered mode of delivery decision-making is first assess amenability. What are your thoughts about this? Then assess suitability, do your obstetric examination, then go back to amenability after there's been some information sharing. Now that we've had this conversation, how do you feel about the birth of your baby? I hope my presentation has aligned with those take-home messages. And with that, I'd like to end. I will share my references in the next slide, but would like to confirm that people are still listening. And if there are any questions or comments, specifically if Vash, my co-author, wants to comment, then this is the time. Thank you.
Thanks, Adam. Good evening, everybody. As a sensitive midwife, my take-home message would be, while women having had a previous Caesar bears the label of high risk, in supporting her right to have a VBAC, I think we as healthcare workers should be mindful not to over-medicalize care, which could be a hindrance to the natural physiology of labor itself. And you nicely spoke about that, practical ways of achieving that throughout your presentation. And this also includes antenatal and birth preparation education that starts way before labor itself, preparing the women for labor, both physically and emotionally.
Thanks for that. Yeah, it may seem quite overwhelming, the things that we're saying in terms of our restrained what am I trying to say? Context, resource constraints. But there are important principles that we should carry forward into every consultation, that this isn't just another pregnancy on a conveyor belt. It's a person who is carrying their baby.
Right. Well, thanks very much for a very comprehensive.
If there are any questions or comments, perhaps Prof. Ross, you can field them. Thank you.
Yeah, I can't see any comments, but I don't know if there are any questions from anyone who has attended. You want to unmute and ask? So it doesn't look like it. So Adam's article is available in the CPD section of the South African Academy of Family Physicians. It's available at the journal. It's the South African Family Practice Journal. So yeah, Adam, thanks very much for that and for your overview and for participating. And I hope you all have a very, very pleasant evening. Thank you very much. Cheers, everyone. Bye.